wonderful speaker, chairs, and the wonderful audiences of the ACNS webinar. We are back again with two wonderful educational lectures for you. The first lecture speaker for today is our honored guest from Nepal, Professor Basan Pen. Professor Pen is the chairman of Annapurna Neurological Institute and Allied Science, Kathmandu, Nepal. He's also the chairman of the Annapurna Research Center and past president of the Nepal Association of Neurosurgeons. His research centers on epilepsy, functional and vascular neurosurgery. He's an important member of NESN, WFNS, and ACNS. He is a recipient of several awards and honored for his outstanding contribution in neurosurgery. He's a noted author for more than 80 publications and is invited faculty to more than 300 conferences and workshops all around the world. We are extremely honored to have him today, and he will speak on lesioning versus DBS in movement disorders. The chair for the first session now is our honored guest from Japan, Professor Hidenori Sugano. Professor Sugano is the director of Juntendo Epilepsy Center, Associate Professor, Department of Neurosurgery, Juntendo University, Tokyo, Japan. He's an important member of Japan Neurosurgical Society, Japan Congress of Neurological Surgeon, and Japan Society of Pediatric Neurosurgery and Japan Epilepsy Society. He's a noted author with several publications in various peer-reviewed journals, and we're extremely honored to have him to chair the session of Professor Basan Pan. On behalf of Education Committee and ACNS and Professor Yoko Kato, I would like to welcome all the chair, speaker, and wonderful audiences to this online platform. And warm welcome to our colleague in China, and we are extremely thankful to Professor Bingzu for broadcasting this webinar on WeChat channel. And with that introduction, I would like to call upon our first chair, Professor Hidenori Sugano, to call upon our first speaker. Professor.
Hello, everyone. So my name is Sugano, Juntendo University, Tokyo, Japan. Our first session is functional neurosurgery. So it's very honorable me to introduce the prestigious Professor Basant Pant. He's also I heard he is the #1 neurosurgeon in Nepal, and he is very experienced. He has a very high experience of the functional neurosurgeries. My expertise is epilepsy surgeries. Now I'm studying about the DBS and something like that. Today, I'm very looking forward to hearing his lectures. Professor Pant, please go ahead of your lectures.
Thank you, Professor Sugano. It's a big honor for me to be able to talk with you all. And thank you, Professor Liu, for your kind introduction. ACNS is, I have been pretty close with ACNS for a long, long time, from the conception of this organization. And then I have been a little bit away because I was pretty busy in my work, but then now I would like to come back and share whatever experience I have gathered during this period, especially coming back to Nepal and working. Today, can you see my slides?
Yes, Professor.
Yeah. So today I would like to talk about lesioning versus DBS. And mainly my focus will be more on lesioning rather than DBS, because lesioning has been, fading away at some time, and now it is reviving again. And these are our co-authors, especially Dr. Resa Shrestha and Pritam Gurung. This is two neurosurgeons whom we are grooming, and they are independently doing this surgery now. And one of the major, our team member are biomedical engineers, and we work very close with biomedical engineers. They also work with us in different specialty, but then mainly in DBS and listening. I would like to remember Professor Thaira again, who is a great friend and a great teacher of us. And he is the one who taught us how to do functional neurosurgery. Initially, I thought, such surgery will not be possible in Nepal. But then he came with all the wires and and then he said, okay, you can do it. The motto of our institute is to learn from the best people. You learn from the best people, and you can improve on whatever you have learned. And then it's your duty to hand it over to the next generation. So we are very, very fortunate to learn this from one of the best person in the world. This is our team. These are the neurosurgeons, and on the two extremes, beard guys are the biomedical engineers, extremely important people for functional neurosurgery. So our journey to functional neurosurgery has not been, straightforward. We took quite a long time to reach this place. We started epilepsy surgery from 2002. When we started epilepsy surgery, we started with very, very simple epilepsy cases like mesial temporal sclerosis, right side, no confusions. But then we went into spasticity, like doing selective neurectomy or selective dorsal rhizotomy. Then from 2006, we started doing movement disorder, lesioning. And then we started DBS in 2014. And from 2020, we have started doing psychosurgery as well, mainly on OCD. This is the first case of 2006, how we did our lesioning on hand dystonia. This is a writer's cramp patient, and this is a Komai frame. And we didn't have a radiofrequency lesioning, so we used the monopolar, and we made our own probes, and we tested the whole thing on the egg. And with air encephalography and CT guided combined, we did this surgery. And initially we did about 7 surgery like this. Then we realized that, maybe we need to have more sophisticated equipments to give a better result. So if you come to the, history of movement disorder surgery, in 1950, actually the anterior dorsal pallidotomy was started. And when levodopa came, then lesioning was almost stopped. And then Benadid started in 1987 DBS, but still there were people who were doing lesioning, And in 1990, Lakesell and others did the posterior ventral pallidotomy. And the result was so good that it's researched from that time. But still there are, different ways of making lesions like gamma knives or MR-guided focal ultrasound lesioning. These all are lesioning. So what is DBS? I think deep brain stimulation is a misnomer. We are not stimulating anything. We are actually suppressing the brain. We are not activating the brain, but we are actually suppressing by giving a certain frequency on that area. So by listening also, you are doing the same thing. The only difference is that with time, you can increase the power of DBS, and maybe the parameters you can change because, Parkinson is a progressive disease. So you need to, increase the frequency as the disease progresses. So probably that is the biggest difference between DBS and listening for me. Otherwise, everything else looks the same. So for Parkinson's disease, we have got pretty strict inclusion criteria. They should have a idiopathic Parkinson's disease. All of them should be dopamine responders. We don't do DBS or listening on dopamine non-responders. And they should be medically and physiologically, psychologically stable patient. And if there's a drug-related adverse effect like dyskinesia, and these are very, very good candidates. Our exclusion criteria are atypical Parkinson's disease or Parkinson plus syndrome. We don't trust these people. And progressive supranuclear palsy or patients who are not responding to dopamine. How we do it? We either take a MRI, 1.5 Tesla or 3 Tesla MRI with no spacing. So volume scan, we take a volume scan. And then we put the patient on a stereotactic ZD Fisher frame. And then either 16 slice or above a CT scan is done. We work on CT based, but then we fuse the CT scan with the MRI. So fusion of CT MRI is done. And then ACPC line is determined on MRI. Then suppose we are going for GPI, let's say, then we have our primary target. These are our primary targets. And then we also make a secondary target. So we go in two places, which is 2 millimeter lateral and 3 millimeter posterior to the primary targets. So red is the primary target and yellow is the secondary target. And there's a paper written by one of our colleagues on Asian Journal where we have studied the ACPC line, because we find that the ACPC line there's a lot of variation in ACPC line. And if you look at this, then we are in between the Hispanics and the Europeans on ACPC line. So once we have fixed the target, we reconfirm the target on axial and coronal view on Saltender's atlas. Then the patient is taken to the OR and the frame is fixed on the Mayfield. Then we generally plan 6 targets, 6 lesions. So 2 targets, 5 to 6 radiofrequency lesion. And so before we actually make the lesion, we have this accuracy and safety checklist. So we are doing all surgeries on awake surgery so that we can monitor any complication that is happening intraoperatively, or how the patient is responding on stimulation. So then we do a phantom simulation of the target. Then we do a C-arm verification, and then we also do a microelectrode recording. Once we are confirmed that we are on the right target, whether it's a STN or GPI, then we do a test stimulation at that region and see if there's a complication that is seen. If there's no complication, then we go ahead and do either we do a listening or we do a DBS. So up to that point, it's the same. So this is one of the patients with listening where we are testing the rigidity, the motor, the sensory function, and the vision of the patient. And for pallidotomy, once the target is verified, we use Cosman radiofrequency generator. And first we do a test stimulation where we gradually increase the power up to 3 microvolt and see how the patient responds to that. Then we do a test listening. Test listening is 50 degrees Celsius for 30 seconds. So this is, we think this is a reversible, but then there will be, effect for a temporary time. So if there's an adverse effect, we can, recorrect our position. So if there is no problem, then we see that the desired effect is seen, then we make a permanent lesion, 75 degrees Celsius for 60 seconds. The probe that we use depends on where we are targeting. We generally use 3 probes. This one is 0.75 millimeter diameter with the exposed tip of 2 millimeter. Another is 0.75 with 3 millimeter. And this one is 2 millimeter diameter with a 5 millimeter exposed tip. This big one we use for psychosurgery and not for movement disorder. Because for psychosurgery, you need a bigger lesions. And we have a habit of periodically checking our radiofrequency probes, whether they are properly working or not, every time we go and do the surgery beforehand on ache. So once we reach the target, we make the depth, the most depth one, and then we slide 1.5 millimeter cranial and make further lesions. So generally we make 5 lesions in one side. So as you can see, the GPI lesion is very close to the internal capsule. And this is the optic nerve. It is also pretty close to the optic nerve. So these are the two targets that we always observe, whether, whether we see any dystonic posturing of the hand or whether there is any visual problem. And we want to go as down, as caudal as possible and very close to the, optic tract. And this will be the best. So generally what we do is we go as deep as possible, stimulate, and if there's a visual problem, then we come up a little bit and then make the lesion there. So this is how the bilateral GPI lesioning will look like. And for bilateral GPI lesioning, I will tell again also, there's a problem of dysarthria and dysphagia. So if we need to do a bilateral GPI lesioning, either we stage them for after, we do one and then the other one after 3 months, or if in case of dystonia, which is very, very severe, then we do both on the same side, same sitting, but we ask the patient to, continuously, swallow something and speak, and we always make one side bigger and one side smaller. And that's how, we have learned that we can avoid this complication. So after the procedure, the next day we do our MRI and then fuse that MRI with the previous MRI to see that, actually the lesion that we have made is in the right position, like in this picture. Yeah. And if we are placing a DBS, then we, put that on local anesthesia at the same sitting, like this. And we are using, right now we are using Sindre. This is a Chinese-made DBS system. This has got some very good point, which we liked. And the general, the IPG is placed under general anesthesia and on a pocket that is made on the anterior axillary line like this. And this is the parameter. Generally, in the pulse width is somewhere around 62 to 75. And frequency, most of the time, it's a high frequency that we put the patient on. But then there are few cases, like here you can see there are few cases where we have kept the patient on low frequency because most of the time when they have walking rigidity and hesitation, they have hesitation of taking the first step, then sometimes we find that low frequency is better. And on case-by-case basis, we sometimes put them on most of the time on bipolar, but also on monopolar mode. So as you can see, the rate of DBS has increased so much because of its popularity. But then we continued using both systems in our hospital. We choose. And then we use the both system. I will talk about that later. And about the lead, there has been a lot of improvement on the lead, like directional lead. If you are very close to the internal capsule or some important structure, then you can actually, collaborate and make the electrical activity on one side. Or another very important one, which is also used in psychosurgery, is multiple level stimulation on a same probe. This is being used if you want to stimulate two targets at the same time, especially in psychosurgery like OCD and depression, then this is a good probe. So when we looked at the number of surgeries that we did for DBS, then we found that majority of our patients were coming only from the big city, Kathmandu. And from far away, they had difficulty coming to Kathmandu all the time to correct the parameters. So we also started a remote wireless programming in DBS, where you can actually control the DBS device through internet and through the Bluetooth, the controlling device that you give to the patient. And as I've said, listening is being kept alive by many famous neurosurgeons like Tipu Aziz, a very famous neurosurgeon from UK, and also Professor Thaira. And now, the revive of MR-guided focal ultrasound is also listening at the same time. So if you look at the listening, then there is a lot of papers still coming on listening, and our result is also similar to this. One of the probable reason for listening to get less is because there is a lot of technological input that has gone into DBS, but like the type of device, the type of the lead, and so on and so forth. But for listening, the technology has not moved on, except for radio frequency listening. It has been the same. So we are comparing the technology of the past with the technology of the present. But if you look at the result of the listening, then we don't see a big difference, So then we said, okay, to cover the people from outside Kathmandu who cannot come to the city, we need to do something. So we started more and more listening. And as you can see, and the majority of these listening people are coming from all over the country. And this is one-time surgery, and the follow-up is pretty far away. And this I've already talked. So out of the 86 cases of movement disorder that we have done since 2014, we have done 27% of our cases are DBS, and 73%, 63 cases are listening. And out of the Parkinson's disease, which is 55 cases, 23, so 43% we did DBS, and almost same, 57% GPI listening. And there are one case of pallidothalamic tract, one case of unilateral, otherwise most of the time are bilateral. And other movement disorders, 31 cases, we did only listening, and we never did DBS in other movement disorder, which I described. And the results is 55 cases of PD in both group, mean age, mean distribution, illness, male-female ratio, these are similar. And drop in UPDRS score in both lesions is almost same, but a little bit actually better in listening. So this is the drop in UPDRS score, where there is, it's not statistically significant, but it is a little bit actually better in our series. So for DBS, most of the time we target STN. For listening, we always target GPI, but we have done DBS on the GPI also 3 cases. It can be unilateral, but DBS is always bilateral, and rest I have already said. But the surgical time, if you see, surgical time is pretty, faster in listening. And above all, the cost factor, it's about $2,000 in listening, whereas $20,000 for DBS. So, financial reason is one of the reasons for us to decide on, whether we go for lesioning and DBS. And change in dopaminergic doses, 10% in lesioning, in DBS it is more. And hospital stay is in DBS, it's a little bit more. And if you look at the complications, then we see that one patient had dysarthria, one patient went into Parkinson's crisis, and there was temporary hemiparesis, which I will explain. And in DBS, we have more complications, like one intracerebral hemorrhage. There was one hardware complication where the wire came out and we had to, resuture it. There's one patient of suicide whether we don't know whether this is DBS related, because it is documented in literature that suicide rate goes high with DBS when it's deeper. And there were 4 people died, but with other complications. And for follow-up, as I've said, follow-up is much, much simpler in lesioning. Some examples like of pallidotomy. This patient had a staged bilateral pallidotomy. This is pre-op, and this is post-op after second pallidotomy. This is a 40 years male with Parkinson's disease with very, very severe dyskinesia. And again, on this gentleman, we did a bilateral lesioning one stage, and we could completely, stop his dyskinetic movement. This gentleman who is 45 years had a tremor-dependent Parkinson's disease. As you can see, he has Parkinson's, but a lot of tremor was there. So we did a unilateral pallidotomy, but then his rigidity went off, but his tremor was not improved. So we did GPI lesioning, and we went across the internal capsule and we did a VIM lesioning at the same sitting. And then he became better on the table. For lesioning for other movement disorders, we have 31 cases. And we did no DBS in other movement disorder cases. There were 20 dystonia. So out of these 21, we did 14 one-stage bilateral and 2 staged bilateral, which means 3 months gap, and 4 only unilateral. In task-specific dystonia, we have 4 unilateral BOA, BOP junctional lesioning, essential tremor, 4 cases of VIM, and we have 3 cases of Huntington's chorea. We also do, lesioning for hypothalamic hamartoma. We have 3 cases, and we have 1 case of OCD. And result of dystonia, again, the male-female ratio is not big difference. Our age group is, mean age is pretty young in dystonia patient as expected. And being changed in FMDRS improvement is 81% plus minus 12. And 90% of them persisted to have improvement for more than 2 years. And there were 4 cases of recurrent dystonia. Less than 2 cases came within 3 months, and 2 cases came after 3 months. Because 3 months is the cut mark that we always put. And if the patient comes within 3 months, we think that the lesion is either not big enough or not in the right place. And there is edema around it, so the patient improves for some time. Once the edema goes down, then they have problem again. And there were 2 cases of dysarthria on one stage bilateral. So with this, we started doing one side bigger and one side smaller lesion. There are no mortality in none of our, DBS or lesioning cases. And there is distance hemiparesis infarction, which we have published. I will explain. And there is one patient with central GPI, central dystonia. So like a Meek syndrome, a bit of Meek syndrome was also there. He was okay for 6 years. Then after that, he developed truncal type of limb dystonia, which Professor Thaira used to tell us. And this distance, this is the case where we had a hemiparesis. The lesion was made here, but the infarction, we can see an infarction there. So actually, our hypothesis is that probably we burned the artery that was going into the internal capsule of a perforator. And since it was a motor area, he had, profound hemiparesis. And then, after some time, he improved to some extent, but not fully. He didn't improve fully. This is a dystonia case. Like this gentleman had, he was walking like this for the last 10 years. And from the age of 17. And on this, in such severe dystonia cases, we do, one stage bilateral GPI lesioning. So 2 targets on one side, so actually 4 targets on both sides. So he became completely normal after lesioning, and he is almost 5 years post surgery, and he has no recurrence. Another case of dystonia patient where you can see he has got torticollis. His shoulder is lifted upward and more of right side. And this is again, we did a bilateral lesioning in this case again, as you can see. And then he is walking normally again. This cervical dystonia, central type, where the patient has been walking like this for the last 6 years. He can never see straight. He's looking at the sky all the time in a very positive man. And this is post-op, just one stage bilateral GPI lesioning. About task-specific dystonia, we have done 4 cases, 3 cases of writer's cramp and 1 case of musician's cramp. Here, you can see that she's trying to write in English, but you cannot read it. And we ask them to, interoperatively, we check how they are doing. And also we look at their motor power. So what we are actually doing here is we are disrupting the pathway in the thalamus, which is in connection with the basal ganglia and the motor cortex. So the lesion is made somewhere around here, in the junction of VOA and VOP. So the lesion will look like this. These are 2 different cases. The lesion will look like this on the posterior aspect of the internal capsule. So this is a patient who had a musician's cramp, and he was a professional musician, and but then he could not play properly because he could not play only G. When it comes to G note, then he will stop. We don't notice it. When he's playing, we don't notice, but then he's the one who noticed, and then he is very, very scared that he will lose his job. So we did, this is called a madal, a local instrument, a Nepali local instrument. And for essential tremor, this is a very straightforward surgery where you make lesion on the opposite side of VIM. So this lady is trying to draw a circle and then try to, So pretty severe tremor, and which is leading to difficulty in her day-to-day life. And that is the beam target, which is a little bit anterior to BOA-BOP junction and medial to the internal capsule. GPI would be somewhere around here. So this is what it looks like on the target. Again, we make a primary and a secondary target. If the primary target is enough, we don't make lesion on the second target on VIM. So most of the time, these people will, the tremor will stop on the table like this, and then you know that you have done the job. So you can, check it in different ways. So this lady, after, immediately after surgery, you can pour the water very nicely. We had some difficult cases. This is one of the difficult cases that we had. She had a oromental, spasticity and also truncal spasticity. And we made a bilateral GPI lesion. She became absolutely normal immediately after surgery. Before she could not even open her mouth. But then she recurred. Within few months, she recurred. And we did same surgery again. And she became better again. But then again, she recurred. So she recurred for 3 times. And we did same lesioning 3 times. Every time she became better, but recurred. And at the end, she had more of a truncal spasticity rather than facial spasticity. So eventually we put a baclofen pump on this lady. And after that, she is okay. So our idea is if it's a mixed syndrome where there is a oromandibular dystonia, and if it is a central dystonia, then these are very, very difficult cases. This is, if there's a laterality in dystonia, then these are good cases. So in conclusion, the result of lesioning and DBS is equally promising. Unilateral or stage bilateral pallidotomy is safer than one-stage bilateral pallidotomy. But if you need to do one-stage bilateral pallidotomy, make one side bigger and the other side smaller. And in our case, pallidotomy has surpassed DBS. We are doing mole pallidotomy as it is cheaper and do not require time-consuming adjustment, and there's no hardware-related complications. So our present thought process on movement disorder as a whole is that if it is a dystonia, if it is severe, if the patient is young, like less than 45, we would like to do a bilateral pallidotomy on one stage and lesion smaller on one side. But if it is a mild dystonia or old age, then we want to do a stage pallidotomy. For Parkinson's disease, if it's a less than 60 years, dopamine-induced dyskinesia is there. There's a clear on and off phenomena. And if the patient can afford, then we will put our ST and DBS. But if the patient cannot afford, then we will straightforward go with pallidotomy staged. For PD, pallidotomy has surpassed DBS in our setup as it is costly. I have said this. And for essential tremor, we will go for VIM thalamotomy, which is very, very simple. And for task-specific dystonia, we would like to continue with BOA-BOP junction. And as for pallidothalamic tract lesion, we have got 2 cases of pallidothalamic tract, but our result was not that good. So, we are not doing pallidothalamic tract at this stage, but we would like to look into it again and see, where we didn't do properly. With this, I would like to end and hope to have a normal conference with man-to-man in near future. Thank you very much for your kind invitation. Thank you.
Thank you very much, Professor Pant. So the audience can ask the questions for him using the Q&A. Let me confirm the professor. When you select the target for the GPIs, you are going to lesioning. And when you select the target for the STM, you are going to deep brain stimulation, right?
Yes.
So I have one question from the audience, but I think that you concluded the last slide. The questions is do you always advise bilateral lesioning?
Yes, I think I talked about this. If it is Parkinson's patient, most of them are elderly people, so we would like to do a stage lesioning. And if it's a dystonia, very severe, and young patient, then we will do a simultaneous lesioning. But if it's a dystonia with old patient, then we will go for stage lesioning.
I think the staged bilateral lesioning is the safest. Why do you select the bilateral lesioning for young patient?
Initially, we were doing, especially for dystonia cases, when we were doing unilateral lesioning, then the patient response were not good. They were not happy. They didn't trust us because there were no change. That's why, we wanted to give best result in one go. So that is one of the reason. By doing one side big, one side small, we have, almost completely stopped this dysphagia and dysarthria. And even if there's a dysphagia and dysarthria, we stop. They come back. But if you make big lesions on both sides, then the dysarthria may not come back. This is why.
What do you select the bigger lesion side?
Yes, bigger lesion side, because there's always laterality in these cases. There's always laterality. Parkinson also there is laterality, as you know. So we go for bigger lesion on the worst side. So if it's the left side is worse, we make a bigger lesion on right side.
You said that when you see the recurrence, you did the bigger, you make the bigger lesions, right? So did you change the target more deeper or close medial or something like that?
Most of the time when we have this problem of recurrence, we fuse the pre-target, pre-surgery MRI and where we have made the target with the lesion, new MRI. And if we have missed, especially if we are not deep enough, then we may go deeper. But if we are correct, most of the time we are correct, it's very hardly we have missed the target. Then we make a bigger lesion because we think that the lesion is small, and then it is the edema that has cured the patient for a short period of time, Yeah.
Okay. I have one more questions. You check the neurology during the surgeries. When you see the motor weakness or visual impairment during the surgery, what do you do? Do you continue to lesioning or stop lesioning?
Yeah, very good question. For visual, they will say they see some light, spark of light or something. So absolutely, we will not make lesioning there. We will come up because we are very close to the optic tract. But for motor symptom, many times, if you are very close to the internal capsule, but actually not in the internal capsule, you still have dystonic posturing of the hand. So in motors, if there's a motor symptom only, then we do a test lesioning because test lesioning is reversible. And many of these people do not have any symptom on test lesioning, so we make a permanent lesion. So sometimes this electrical stimulation actually gives you a false impression. And this is a monopolar mode stimulation that you do, and monopolar spreads out, Bipolar is longitudinal, whereas monopolar spreads out. So there's sometimes false positive warning. So test listening is, I think, the best way to correct, see if there's a complication or not.
You mean test listening is small regions or stimulations?
No. Test listening is, permanent lesion is 75 degrees Celsius for 60 seconds. Test listening is 50 degrees Celsius for 30 seconds.
Okay. Thank you very much.
One of the problem of MR-guided focal ultrasound, which is one of the very, very interesting and very, very promising technology, but the problem is that the temperature is not high enough. It's like a test listening that you are making. It generally goes somewhere around 50 only.
You mean in the developing country or bigger countries, the reasoning is better to follow up, right?
Absolutely, yeah. That's our impression.
Thank you very much. So we have no questions from the audience. So thank you very much. So
thank you very much.
I'm going to the second topics. Thank you very much today.
And on behalf of Education Committee and Professor Yoko Kato, I would like to thank Professor Basan for very nice, interesting, and relevant listening, which very affordable to most developing countries. And also the chair, Professor Sugano. And also we thank Professor Bokadi to spend his night without the presence of our main speaker, Professor AJ. And I also would like to thank Professor Bingzu for broadcasting today's webinar. We have around 1,000 participants watching us live from various platforms, WeChat, YouTube, and also from our Zoom session. So again, when we meet again on this coming Saturday, it's bye-bye from all. Thank you to our speaker, our audiences, and our chairs. Thank you.